Welcome to Segment 9, the Basic Nervous System and Referred Pain of the Falcon Physician Reviews segment with anatomy. As we move into the nervous system, we're going to move fairly quickly through this, but this is to make sure that everybody has a great foundation on the basic nervous system and its distribution patterns, so that we can layer on top of that a little bit later all of the various plexuses and whatnot. So we know there's 31 pairs of spinal nerves associated with 33 vertebrae. We know the different regions that they're all distributing to, and that there'll be 12 paired cranial nerves, for making a total of 43 peripheral nerves, even though, of course, we all know that cranial nerve 1 and 2 actually are just extensions of the brain itself and shouldn't probably be considered the peripheral nervous system. In almost everywhere that you'll go, they will be considered peripheral nerves. I like to have a pattern for remembering the cranial nerves, and the pattern that I use is 2-2-4-4. That means that the first two cranial nerves are off the forebrain, the next two cranial nerves are off the midbrain, the next four cranial nerves are off of the pons, and the last four cranial nerves are off the medulla. This gives you a nice simple way of recalling where a lesion may be located in a question, simply by remembering 2-2-4-4 and knowing that they come off from anterior through posterior in that order. These are some terms that you should know cold going into any future studies of your Step 1 preparation. You have to know that a collection of neurons and axons is a nerve, and the supporting cells and connective tissues around that make up the nerve itself. So you've seen these before in histo, the epineurium, endoneurium, and perineurium that all surround the different fascicles and axons. You should refamiliarize yourself with those basic structural things and know, of course, that there's blood vessels and nerves even associated with these, the vasa nervorum and the nervi nervorum. As you go on, you should know that a neuron is a cell body and its projections. And the projections may be into the central nervous system or the peripheral nervous system. By definition, you should know that the nucleus is a collection of cell bodies in the central nervous system. So when you see the term nucleus, you know you're dealing automatically and by definition with a central nervous system issue. Finally, ganglia is a similar term that you should be knowing that it by definition is a collection of cell bodies that are in the peripheral nervous system. So when you see the term ganglia, you'll know automatically that you're dealing with peripheral nervous problems. That gives you a very quick way to sort questions and the options that are available to you by saying, if this is a central nervous system question, I can get rid of all peripheral nervous structures, and vice versa. There are two types of ganglia, and you should know these as well. There are sensory ganglia, which includes both visceral and somatic pseudounipolar neurons. These are the dorsal root ganglia, the cranial nerve associated ganglia, which would include things like the geniculate and some of the superior and inferior vagal nuclei. Also, there's motor ganglia. The difference between the sensory and the motor ganglia is that the motor are only visceral cell bodies, and there is actual chemical synapses that occur at the motor ganglia, whereas sensory ganglia have no chemical synapses occurring at them. Let's move on to a question. As a student, you're performing your first lumbar puncture on a 16-year-old female that's suspected of having meningitis. When obtaining a sample of cerebrospinal fluid, where should the tip of the needle be placed? Hopefully, everybody got this correct, because you want to put this into the arachnoid mater, or just deep to the arachnoid mater in the subarachnoid space, where you'll withdraw the spinal fluid for analysis. As a quick reminder, you should look over all of the spinal cord coverings, the three meninges, and the spaces in between. As a reminder, you should be aware that there are lateral specializations of PIA known as the denticulate ligaments, and there two of those, one on the left and one on the right, and several dentitions for each one. And as a reminder, you should know that this has a reference for things like meningitis, where you have two types. One would be viral, which is the most common, and fungal, or bacterial, which is the most deadly form. The hallmarks of this meningitis are going to be sometimes confusing because they are similar to that of the flu, where you may have fever, severe headache, confusion, vomiting, and a stiff neck. That stiff neck and the headache should be a huge red flag that you must then rule out meningitis. One of the most common causes of meningitis is going to be the pneumococcus, the meningococcus, and listeria, all of which can cause the bacterial meningitis. The viral meningitis is typically caused by enterovirus. You must also review and make sure you understand the typical spinal nerve, that the dorsal horn and the ventral horn are separated by the anterior and posterior half, which is the sulcus limitans, and the ventral horn is going to be motor and the dorsal horn is going to be sensory. You must also know that roots and rootlets are divided modalities, whereas after you get past the dorsal root ganglia and get to the mixed nerve, everything is a mixed nerve. That includes all of the ones that you call cutaneous. Cutaneous nerves contain visceral motor fibers in them, which will stand the hair up on your arms, and they will contract the blood vessels that are in the skin. So a cutaneous nerve is still a mixed nerve, even though clinically we tend to simplify it down to the somatic or sensory problems that people present with. Remember, the spinal cord ends at the L1, L2 disc, and that's called the conus medullaris as it tapers down. The cauda equina are the nerve roots that are bundled within the thecal sac or the dural sac, and the dural sac ends at S2. That horse's tail continues from the end of the conus medullaris through to the end of the thecal sac, where they'll all protrude out to make it to their intervertebral foramina. And therefore, that's why you're going to do lumbar punctures at the L3, L4 level, because you want to give the population statistics of that L1, L2 ending point a wide berth of at least 1 or 2 levels. In younger children, because they haven't had the anterior and posterior growth of the lumbar curvatures at that point, you want to go 1 level lower. Remember that there are plexuses, and those have dermatomal distributions as well. But the plexuses are going to be 4 in number, and they are only combined of ventral mixed rami that will braid together. Plexus means to braid. There's a cervical plexus, C1 to C4. There's a brachial plexus, C5 to T1. There's a lumbar plexus, which is going to be including T12 all the way to L4. And then there's the sacral plexus, which is part of L4, all of L5, which makes up the lumbosacral trunk, and down all the way to S4. Let's do another question. A male in his mid-60s has weeping and painful blisters distributed across the left side of the T7 dermatome. Where would you expect to see the blisters on the body? This is one that hopefully you were able to deduce from some of your common knowledge. There are several dermatomes that you really need to be aware of because they have high yield payoff. The T7 dermatome goes right across the xiphoid process. If you were thinking of some of the other ones, the vertebra prominens is going to be up near the T1 and sometimes the C7 vertebrae. Then you have the base of the axilla, which would be around the T1 dermatome, sometimes a little bit of T2. And then the umbilicus as the T10 dermatome, and then the nipple as the T4 dermatome. So there's a little bit of a reminder of all of the various ventral rami that combine into the various plexes. then we talk about the dermatomes. You really need to have mastered the difference between a dermatome and a cutaneous distribution, because this has clinical significance for solving problems. So the dermatome, by definition, is a somatic sensory distribution from a strip, let me repeat that, from a strip of skin innervated by a pair of spinal nerves. There's enough overlap from one to the other with redundancy from each strip that you actually have to have two adjacent segments being affected before you'll have a sensory deprivation along that strip of skin. They're all numbered, so they have spinal cord segments associated with each one. A cutaneous nerve, on the other hand, are the axons from multiple dermatomal segments that will braid together in the plexuses to provide a patch. Let me repeat that. These are a patch of sensory supply. They're going to be sensory and visceral components. They are mixed. Various spinal levels that braid together to distribute to a patch of skin, and these all tend to be named, i.e. the lateral femoral cutaneous, the lateral antebrachial cutaneous. All of those tend to have names. What's the difference in the significance clinically when it comes to USMLE and clinical preparation? The difference is that when you know that you have a strip deprivation, that automatically gives you a clue that you're looking at a more central nerve problem or distribution problem. When you see that there is a patch of skin that's got sensory deprivation, automatically you should be thinking about a peripheral nerve after the plexuses have braided them together. And finally, the myotomes are going to be the equivalent of a dermatome, where there's one segment of a spinal nerve that's actually distributing to the motor components of a muscle. And the myotomes also tend to have overlap so that you don't have paralysis with a segmental injury as much as you would weakness. For instance, the biceps, and the musculocutaneous nerve is the C5 and 6 components of the myotome. The myotome C5, though, would be all of the motor axons that distribute from the C5 segment. And there would be combinations through the plexuses with, in this case, C6 myotome. Here's a list of some of the key dermatomal levels, and I'm not going to spend time with this right now. You should remind yourself of these and just pause the slide if you need time to familiarize yourself with these again. One last time, it's really important that you understand dermatome versus cutaneous nerve distribution, because you will be able to sort information on questions much faster. Dermatome, one segment of skin supplied by a single spinal nerve. They tend to be spiraling because of the limb association, and in different areas they have different widths. In the lower limb, they tend to be around a hand's width, or 4 fingers. In the upper limb, they tend to be about 2 fingers wide, maybe 3 fingers, and in the thorax and abdomen, you can rely on them being around 2 finger widths wide. So you can count them using the person's finger widths. Here is how the redundancy plays into the dermatomes. If we have a strip of skin supplied by L3, it is redundantly covered by portions of L2 and portions of L4. If we were to knock out just L3, we would have no sensory deprivations. If we knock out L3 and L4, now we'll have sensory deprivations, and they will be organized in a strip. When you go towards the cutaneous nerves, these cutaneous distributions are going to be combinations. So you can see as an example, the anterior femoral cutaneous nerve actually contains L2, L3, and L4 into those different components with medial, anterior, and lateral sides of that anterior femoral cutaneous. These are going to be supplying patches of skin, and that tells you that they've woven together in the plexuses. The lateral femoral cutaneous is a patch of skin supplied by L2, L3 axons, and then you'll have various other ones that we'll talk about when we get to the appropriate limb. let's all remind ourselves of the organization of the nervous system in general so that we can carry this idea forward and make sure everybody's on the same page. If you already have a solid understanding of this, move quickly through it. There's the central nervous system and the peripheral nervous system. They have a bi-directional communication going on between them. If it's going from the PNS to the CNS, it's called sensory or afferent, and if it's going the other way, it's called motor or efferent. Each of these systems have both somatic, which is the system that deals with the voluntary system, and it moves you through or gives you information back from your external environment. Whereas the visceral system is involuntary, and it moves things through and gives you feedback from your own internal environment. Each of them has a motor and a sensory component to it. The somatic system has motor targets, which are skeletal or voluntary muscle, and the sensory side of this are the different modalities, which I refer to as PT, which really refers to the pain, pressure, temperature, and touch. PT. This sensory feedback is always pinpointable, meaning if you ask somebody where it hurts, they point directly to the area that's affected. Unlike the visceral system, which has motor and sensory components, we'll look at those on this slide. Remember, it's visceral, motor, and sensory. The motor side of the visceral system, and this is a misconception that I want you to make sure you're clear about, is the autonomics are only the motor side of the visceral system. So autonomics is not the same term as visceral. Autonomics is only the motor side of the visceral system. The visceral afferents or visceral sensory fibers are the sensory side of the visceral system, and they tell you what the motor system is up to. Well, if it's a motor system, we can now divide it down into what we know as the parasympathetic and sympathetic system. Parasympathetics are resting and repose, and sympathetics are fight and flight. The fight and flight system revs you up. The parasympathetic system pulls you down. So it decreases heart rate, decreases respiratory rate, whereas sympathetics do the opposite of that. So they are, as systems, antagonistic. But they are not always distributed to the same areas. They do in general distribute, however, to the same targets. They go to cardiac muscle, glands, and smooth muscle. The big difference is that they tend to go to different glands and different smooth muscle areas. So just because they are antagonistic systems does not mean they go to the same targets all the time. Let's think of an example. The sympathetics tend to go to the smooth muscle that makes bags and tubes that have blood in their lumen. Therefore, I call that vascular smooth muscle. The parasympathetics tend to distribute to smooth muscle that makes up bags or tubes that do not have blood in their lumen, and we'll call that non-vascular smooth muscle. Do not confuse that with avascular smooth muscle. All smooth muscle needs blood vessels. So, we have the parasympathetics that distribute to non-vascular tubes and the sympathetics that distribute to vascular tubes. So where are vascular tubes? Well, they exist everywhere, therefore sympathetics distribute to the entire body. Where are the tubes that don't contain blood in their lumen? There's things like the stomach, the ureter, the uterus, the esophagus, lower components. All of those contain things other than blood. Therefore, they stay where they're distributed, which is the body cavities. So you tend to see parasympathetics only distributing to body cavities, whereas sympathetics, because they follow vascular tubes, need to distribute everywhere. On the sensory side, they have different modalities than the somatic system. In the sensory or the visceral afferents, they pick up stretch and distension, carbon dioxide or oxygen partial pressures, or blood pressures. Therefore, they are not the same pinpointable system as you have in the somatic areas. These are what's called a gated system, and they have links to the somatic system in the spinal cord, and we'll talk about how that referred pain occurs from that link in the spinal cord in a few moments. So what they need is they need a lot of input in order to reach this gated threshold in order to get a firing from a visceral sensation up through that link in the somatic areas of the spinal cord. And that will take the non-conscious feedback that we tend to get without needing to think about it to the conscious sensors in our brain. This kind of pain, because it has a broad and global input to reach the gated threshold, tends to be diffuse and not pinpointable. And that's therefore called referred pain, because it's your body's way of hijacking a somatic sensation area and trying to get it to pay attention to a problem that's going on in a visceral system. See how this works graphically. If we have sensation in the skin, there is a receptor that picks up a sensation, let's say a vibration from touching something with your index finger, that will then fire an all or none electrical signal from the skin all the way through the dorsal root, which will impact the next neuron in the chain, and that will take it up to the conscious centers of the brain, and you will be able to pinpointably identify what has been stimulated. In a visceral system, you have some gut that's, say, low on oxygen, so it has an ischemic feedback. This always goes to the brain. Notice how the cell bodies of both of these are in a sensory ganglia in the dorsal root ganglia, but there's no communication between the motor the somatic system and the visceral sensory systems at this dorsal root ganglia. This gut is always getting feedback to the non-conscious centers of the brain as an all or none firing. But what it does is it has a little connection that we'll look at after we see this all or none firing. So it will always drop enough chemical on that secondary neuron to take a signal to the non-conscious centers. But what it also does is it drops a small packet of information or chemical information onto the conscious receptor in the spinal cord. And then this is not enough to stimulate it because it hasn't had enough input. But if there's a lot of gut receptors that are activated through ischemia, then they'll all drop these little collateral contributions onto this somatic neuron, and what you'll get is a firing of that neuron to the conscious centers. How has it been stimulated then? We have a conscious neuron from the somatic system that has been stimulated through global inputs from a visceral system. We're still getting non-conscious information, but now we've got our body's attention. So where did this referral from visceral system to somatic system occur? In the spinal cord. And that's the concept of referred pain. And you can see that this one picture has so many endings on it that there's a lot of global inputs coming from all over because of these little collateral sprouts that come off of many of these neurons, both motor and sensory. So, what is referred pain? Referred pain is a conscious perception as a result of visceral feedback upon somatic afferents in the spinal cord or brainstem. What does it mean in the terms of questioning? Well, let's look at one. A 16-year-old is admitted to the ER following a skateboarding accident involving a parked car. He's anxious, tachycardic, and feels short of breath. He complains of nausea and gripping left upper quadrant pain and feels he's also hurt his left shoulder. What is his most likely injury? So here's a patient that's hit a left side of their body into a parked car, and they think they've hurt their shoulder and their abdomen. If you're astute and understand the impact of referred pain, that left shoulder pain that he's feeling could actually be a referral because of a splenic laceration. Remember, he's also tachycardic and feels short of breath or nauseated. This is a sign that he may have internal injuries and bleeding into his abdomen or one of his cavities. So, when we look at referred pain, as we can see in this diagram, there are several areas that can be interpreted by the brain's conscious centers as having issues when really it's referred pain from a visceral system. And when that happens, notice how people will say that their pain is diffuse, so they have big hands when they point at it as opposed to a single finger pointing at their pain if it's actual somatic pain. Here we've lit up the spleen to show that it's hurting at the right side, and you can see also up top that we would have the shoulder pain as a referral, because the blood that's leaking from this splenic rupture could actually irritate the diaphragm, which would then give a referral up to that left shoulder on the same side as the injury. As the peritoneal bleeding continues, though, you can expect other areas to become lit up as well from referral. And this is where maybe the nausea will start to come in as well. And I picked spleen because it's one of the most commonly injured organs by very blunt traumas. And you may also see signs of shock and pallor start to take over in a patient like this. You may see rebound pain or the diffuseness of the abdominal pain as the bleeding starts to get beyond that 10% of the blood volume into the abdominal cavity. And this could be a very serious injury, and if you don't understand referred pain properly, you may miss it for a time period, which makes their recovery impossible. Well, that concludes our 9th portion of the anatomical review on basic nervous system and referred pain. The next section will be looking at lower limb organization. Well, that concludes our 9th portion of the anatomical review on basic nervous system and referred pain. The next section will be looking at lower limb organization.